My name is Dr. Jason Diaz. I am very happy and honored that you've chosen to spend some of your very busy day with me today. And just a little bit of housekeeping as far as participation. My intention, this is the third kind of COVID conversation I've hosted here, and my intention is to allow space for you all to add your thoughts, your expertise, your questions as well. So I have some prepared slides. We're going to get through those, and I'm going to finish those around 5:30. As I go through those, if something I say sparks a question or a thought, please feel free to either record it yourself, put it in the chat, etc. Once I'm done with my presentation, I will take a scan through the chat to see if there are common themes and think about how I might order responding to those. I'll respond to those first, and then we'll kind of have a more open dialogue and kind of see where things go. The session should end around 6, but if things go on a little bit after then, you want to stick around, I can maybe stay for a little bit longer. All right, so having said all that, let's get this going. Just need one more moment to move my Zoom windows. And perfect. Okay. So as I said, this is my third talk that I've kind of called COVID Conversations, and this is really supposed to be, again, a back and forth. And before we kind of really dive into it, I just want us to reflect about kind of who we are and where we are in this present moment and what we are bringing to this space together. So what kind of anxieties, fears, concerns are we bringing? What kind of questions are we bringing? What kind of perspectives are we having about this moment, and how we're trying to stay safe and informed and maybe help others in our care or in our workplace and all of that. So really kind of take stock of what we're bringing. And then also I would invite you to think about who else is on this call, right? What are they bringing in to this conversation? How might their concerns might be different, or perspectives might be different from what you're bringing in? And can we enter this space open to seeing what other people are experiencing and being willing to have a dialogue to kind of share and try to work through this together? And in that vein, I just want to share a little more about myself. So I have a PhD in cell molecular biology with a subspecialty in virology. So I come to this moment and this talk with expertise in something relevant to COVID, but notably, I'm not a physician, right? I'm not an epidemiologist. I'm not a public health professional. And those different domains of knowledge and skills do bring additional things that I may not have been trained in, but have been slowly learning as well. And I am very happy to have folks on the call who do have expertise that's, I think helpful to contribute to the conversation as well. I'm a science educator. I am assistant professor of the Integrated Science, Business, and Technology program at LaSalle University. And some of the more personal things that I bring to this, in addition to my formal training, is I'm part of an immigrant family, which has had a particular experience of the medical care system and also just education and perceptions around vaccinations and things like that. I'm a gay man, so again, thinking about things like HIV and other kind of related things and how that has informed my perspective on COVID. And especially important at this current moment, I want to be very clear that although I've tried my best to really understand and take into account the experiences of parents and people who are taking care of children and other dependents who can't be vaccinated, I am not currently responsible for children. And so my perspective is inherently going to be a little bit biased. And hopefully if I say anything that is a little skewed from the experiences of parents on the call, you all will be able to bring your perspectives in. So I'm going to focus a little bit in the next 20 minutes on 3 major themes, which I feel are, I think, the 3 biggest talking points right now with COVID. And that is the question about breakthrough infections, the question around boosters, and the question around child vaccinations. With the first and third themes, I think spending a little more time, boosters will be a little bit shorter. So first, of course, I was saying before the recording that I think every time I've done this particular conversation with Venture Café, like days prior to the presentation, some like big COVID news happened. So in this week, the big news was on Monday, the FDA granted full FDA approval to the Pfizer vaccine, which now has the trade name Comirnaty. And that is, again, full approval for folks who are aged 15 and older. For anyone who wants to figure out why the heck it's called this, right? Comirnaty is like a portmanteau sort of CO from COVID. The Mirna is mRNA, whatever. It's silly, but just in case that was baffling you. I'm sorry, 16 and older. Ages 12 to 15 still have the emergency use authorization, which allows those young people to be vaccinated. But of course, we still don't have approval whether emergency use or not for anyone under the age of 12. One of the things I will note, though, is that full approval does open a little bit more pathways legally and policy-wise for implementing vaccine mandates. So you're going to be continuing to see that happen in businesses and services. And relevant to children, there is already a practice of pediatrics doing some off-label use of approved drugs and vaccines in younger people. That being said, right, this is I'm not saying that all pediatricians will do that and how they might do that, and there are some risks involved with that, but I just wanted to throw it out there as something that we may see, and we may see the professional organizations for pediatrics kind of weigh in on how you might do this if pediatricians choose to take that option. And we'll revisit that when we talk about childhood vaccinations. So let me talk about breakthrough infections. And actually, I just realized before I continue, the Moderna vaccine has not been fully approved yet, although that will probably happen shortly as well as J&J. So these are also going to be coming in at different timelines. But in any case, I think this is a big success story and something to be excited about. So breakthrough infections. Just a quick little background. So we like to think, and it's I think common knowledge or wisdom or perception that vaccines are really good at preventing disease, which is true, but preventing disease doesn't necessarily mean preventing infections. And actually, a lot of vaccines don't necessarily provide 100% reduction in transmission. So you may still spread the disease and actually get infected, but your disease might be so mild you don't even realize it, or what you think is just a cold might be a very, very mild case of measles because you happen to be really strongly vaccinated. I choose measles as an example because we do know that actually there can be breakthrough infections which are very, very mild for measles. And of course, for influenza, we know that due to challenges with flu, those vaccines are mostly reducing in disease. Now, all licensed vaccines really kind of, for them to be licensed, meaning for them to be seen to be effective, they have to reduce disease burden in some way. We just call a breakthrough infection a vaccinated person who still gets infected. Now, the breakthrough on its own doesn't tell you how sick the person got. It just tells you that they got infected, and we can kind of see that by diagnosing them in a variety of ways. So when we're talking about breakthrough infections, we also want to add on to a more nuanced perspective of, okay, breakthroughs are happening, but what are we also seeing about transmission for these breakthrough infections and disease burden, right? Because it's one thing if people are getting infected, but the transmission rate is still very low, and or people are getting infected, but the disease is very low, right? Because if transmission is still a concern at a time where not everyone can be vaccinated, that's going to be a public policy issue. And that's kind of where we are right now. So to help me kind of think through that, I'm going to talk about two pieces of data that came out also this week. So really you're getting like very, very up-to-date current info. The CDC provided some interesting reports 2 days ago. The two things I'm going to show you were literally published on August 24th, the same day. And I think looking at these two data sets will tell us something a little bit about what's going on with breakthrough infections. So this first story is looking at Los Angeles County specifically, which, Los Angeles County is about 9 to 10 million people. So that's a huge set of people from May 1st through July 25th. And using their database system for tracking infections and vaccinations, et cetera, in Los Angeles County, the CDC was asking what's happening to the rate of infections and hospitalizations in vaccinated versus unvaccinated residents. And if you look at the entire time period, these are the numbers that they have. They had vaccinations separated by full vaccination and single dose. I chose to combine them here, but this is just a snapshot of, I think, the most important pieces of data, which is that almost a full third of the folks who went to the hospital with a COVID diagnosis were vaccinated, right? And that percentage is, making people understandably very anxious. That seems like a lot, and it is. It's a good proportion. A third of people are, not hospitalized, being infected and diagnosed. If we look at hospitalizations and deaths, though, we see that by and large, the vaccinated folks are much less likely to end up going to the hospital and less likely dying from it. And we're going to break this down further in a moment because these numbers are an aggregate. And from May through August, or July rather, and during that time, the vaccination rate of the county increased pretty dramatically. Also, the prevalence of Delta dramatically increased. And so this kind of aggregate snapshot is not very useful in really understanding the dynamics of what's actually going on with breakthroughs. So in this report, they further broke it down by time, which I thought was very useful. So here they're doing what's called rolling age-adjusted average. The statistics behind that are not super important. Basically, it's a relatively accurate view in 7-day windows of kind of what's happening in this particular graph with infection, so diagnoses of COVID. And we can see in the blue lines, both the dotted and the complete blue lines are vaccinated folks. The hashed black line are unvaccinated. And we can see that it really starts to ramp up pretty dramatically for all people in July, but especially for unvaccinated. And they also were able to show a different set of data in this report, the prevalence of Delta. And basically in May, at the start of this time, Delta was about 8% of all COVID infections. By July, it was 90%. So this is kind of an example of why we are saying that Delta is definitely more infectious, because we can see the infection rate dramatically grows up when Delta is the most prominent strain. That being said, even from this data right here, we can see that if we ask how likely is it that you're going to get infected with COVID, unvaccinated folks are 5 times more likely to become infected. What about hospitalizations? So here's the data from the same report for hospitalizations. You see that vaccinated folks, even through July, their hospitalization rate is actually still very low, whereas it really spikes up for the unvaccinated. And using the statistics that they chose to do, we can see that it's about almost 30 times more likely to be hospitalized with COVID. The number of total deaths is low enough that it didn't make sense to do this kind of breakdown for that, but you can kind of assume and imagine that it's going to be a similar dynamic. So these data are encouraging in that they're showing that even though a full third, right, a full like 30% of infections are in vaccinated folks, the outcomes of vaccinated, unvaccinated folks is still dramatically different. So that is encouraging. It tells us that the vaccines are still working to help reduce disease burden at the least. However, there's always a but. Same day, different report. This report is now looking at healthcare workers at 8 different hospitals in the U.S. And this is looking from December all the way through early August. And when they were looking at the rate of infections for healthcare workers, which I will note, the reason why this is important is that they are doing surveillance screening of healthcare workers pretty robustly and quite a lot. And so they're going to be able to capture infections a lot more frequently than the general public. And what they found was that if the question you're asking is, do folks get symptomatic disease at all, meaning do they experience any symptoms at all, the vaccine effectiveness is clearly lower now, when now that Delta is prevalent. So it went from 91% effective at preventing any symptoms to 66% effective at preventing any symptoms. So again, any symptoms, including mild symptoms. So how the heck do we put those two pieces of data together? We can say that vaccine-induced immunity against Delta is definitely weaker. We know that because the number of infections is going up and people are becoming more symptomatic. But how badly symptomatic are they becoming? We still have clear evidence that vaccinated folks are really not being hospitalized nearly to the same extent as unvaccinated folks. What I did include here, which was a report that came out yesterday, and at some point I had to stop working on this and work on other things. But I can tell you that people are asking the question about transmission. And we're still trying to figure out to what extent vaccinated folks are able to transmit the virus to others. It seems that there is data showing that vaccinated folks have a lower rate of transmission, but it's definitely not zero. And that's going to be relevant to our discussion about children in a moment. But it's kind of how I think about breakthrough. So how nervous should we be about breakthroughs at this moment? I think from a public health standpoint, where making sure the healthcare system is still working and operating, I think we have reason to feel okay, right, about how vaccinations, but clearly Delta is a new curveball, and who knows what the next variant is going to do. So it's something that we want to be worried, that we want to be mindful of. And this segues into our discussion about boosters. So very quickly about boosters, I think anyone who's been vaccinated knows that some of your vaccines, you need to get a booster shot every couple of years, like the tetanus shot, you want to get a boost every 10 years or so. And this is just because our immune system has developed in a way such that really every time it sees the pathogen, it's going to respond very strongly and then build up more memory to it. So the more times it sees the pathogen, in many cases, the better and more long-lasting the immune response is going to be. But it's not infinite, and every disease is a little bit different. Every pathogen is a little bit different. So you really do have to kind of learn for each pathogen's immune response, kind of what works best. And so how do we decide when and how often we need boosters? We want to look at, what are the markers of immunity? So for antibodies, is there an antibody level that we know will protect people from disease? And if we see their antibodies dropping below that, is that a cause for concern? And also looking at real world data, right? So are we seeing an increased number of infections, and can we correlate that with, again, that drop in antibodies, et cetera? And so why are we talking about boosters? Well, the data I just showed you is already, I think, indicative that the Delta variant is clearly able to infect better and faster. So that's maybe indicative that maybe, a booster to increase people's antibody in their body might be useful. But really kind of the data that people have been looking at is Israel, because Israel's vaccination rollout was faster and earlier than ours. And so they've been really kind of the canary in the coal mine for the US as far as seeing kind of what's happening in the real world. And they were able to see and show pretty convincingly that as we enter into the age of Delta, there is definitely more infections going on, especially in folks who are older. And preliminary results when they started actually doing boosters showed that, yeah, we do see an increase when you do the booster of antibodies and immune response. And then we also see the beginnings of a reduction in infection. It's a little early to know exactly like how much of a reduction and things like that, but we see some evidence for that. So because of that, the CDC had already recommended boosters for immunocompromised people because their immune system was already so weak anyway. But the Biden administration kind of went out based on all this data and is now recommending and planning to make available booster shots for everyone who's been vaccinated 8 months. The earliest would be 8 months post your last vaccination, and boosters can start being available, I think, in mid-September. The FDA and their advisory panel have come around to supporting this plan. The CDC hasn't, I think, weighed in yet, at least as of last night, as far as I can tell. And so this is now going to be an option for us. This is a little bit controversial because while there's data supporting this might be useful, there's also the fact that globally, we are still very much an unvaccinated globe. I think that the average rate of the entire globe put together is like 26%, right? And it's not like these Delta variants are coming out of nowhere. They're coming from places where vaccination rates are very low. And the new variants that we're already tracking are also, again, coming from places where there's not high vaccination rates. So there's a lot of debate about the supply issue, whether we should be doing boosters rather than supplying more vaccines around the world. The Biden administration has said they're going to do it's a yes and situation where they're going to make sure there's supply for boosters and donating more doses globally. These are policy questions which I'm not going to necessarily weigh in, but I just want to talk from a science perspective, kind of some of the debate around boosters. All right, I might go a little longer than 5 minutes on children because they deserve it, but that is going to be my last theme, which is childhood vaccinations. And again, before I do this section, I want to make clear that I don't have children of my own, but I'm hopeful that the next couple of slides will be helpful for the parents on the call and anyone else who's taking care of kids. So first, I want to explain why we still don't have approval for childhood vaccinations. And one of the reasons, just kind of a behind the scenes design perspective for clinical trials, is that most drugs and especially vaccines follow what's called a step down approach to doing clinical trials. And that's because, especially for vaccines, which are generally going to be given to people who are not otherwise sick, the ethical burden for making sure there isn't harm is higher than most other drug classes. And so generally, you're going to start with healthy populations where you're not expecting any complications. And so generally, healthy adults are going to be enrolled first, monitored throughout time, and then those clinical trials will stop enrolling patients. They'll be tracked for however long they need to for the disease, and then the data is collected and submitted for approval. Now, you don't necessarily have to wait till the very end to start on your next segment. While you're collecting data on healthy adults and can see that we're not seeing any crazy adverse side effects, now we can also start doing clinical trials in adults who may have complications or other reasons why they're risky. So these are immunocompromised adults, adults with other diseases. This is also pregnant people, right, who obviously have a higher, I think, ethical burden for testing drugs and things like that. And then, once you see in the adult population where adults can provide consent and informed consent for themselves, then you also start going to pediatrics where children cannot provide consents, right? Parents or guardians provide assent for their children and their children, right? They're still developing. There's this idea that because they have more years ahead of them than adults generally, the concern about long-term effects is more salient, right? And so I kind of divide this to older pediatrics. So this is like the 12 to 18s and then 5 to 11s, et cetera. So this is the model, and the model is because we want to be very careful about diving too quickly into what we have decided as a society is the most vulnerable population that we have, which is our children, right? That being said, it's very frustrating to be at the moment where we have the Delta variant, which we know is more contagious, right? And we see more and more hospitalizations because of that, and we still don't have approval. So we're somewhere around here. Actually, we're probably closer to the end that I've depicted here, but I just want to explain kind of the strategy. While also say another complication is in the older pediatrics, we were able to see a very, very rare but measurable increase in something called myocarditis, especially in males. And this was more likely to happen in younger males than older males, younger males being like the 15 to 24 age. And so the FDA actually asked Pfizer, before you submit your data, we actually want you to extend your clinical trial more so we can make sure that this is not also happening in our younger kids, or if it is, we know to what extent we should be worried. So part of the delay has also been because of data we got from older pediatrics, we know some things we want to be looking out for in our younger kids. And so Francis Collins, again, earlier this week, kind of weighed in on kind of the timeline. So Dr. Francis Collins is the director of the National Institutes of Health. And he was saying that he doesn't expect full approval of childhood vaccines to happen before really the end of the year. Emergency use authorization, he expected that may happen maybe as early as October. Pfizer was planning to submit data for all of this in September for the emergency use authorization. I'm hopeful that they are still on track for that, but we'll see what happens. So I'm expecting with the off-label use and submitting the data for September, we may see emergency use for these younger kids in October or November, but I think that it's something we'll just have to kind of keep track of. So having said all of that, I know that I did not necessarily allay any fears for the parents on the call, right? I'm just going to be honest, right? And I know that if I was a parent, things that I would be concerned about are, we are in a moment where there's a new variant that's much more contagious than previous, right? My kids can't be vaccinated, so they can't benefit from any of that good data that I even showed you earlier today. Schools and my workplace have all sorts of different mitigation strategies, which may or may not actually be reducing my exposure to the extent that I feel is adequate. And we see breakthrough infections happen where even if I feel that I may not end up in the hospital, knowing that I could be asymptomatic and give it to my kid is going to keep me up at night and forever, basically, right? So these are just some of the questions that our parents are trying to navigate. And so I'm not going to say don't be worried, obviously, right? You have every right to be anxious. And in talking with other parents and also actually parents who are virologists and infection preventionists who are also trying to navigate the data, I just have some ideas of just kind of how to grapple with this, because really this is a very nebulous fear and anxiety that we're grappling with. And there's like, we're not really sure what to make of the hospitalization data versus the infection data and all that stuff. So first, I just want to again emphasize that even with the Delta variant, the relative risk of harm from COVID is low. It's not zero, it's still very low. So hospitalization of children, even with Delta, is still about 1%. However, which on one hand is pretty low. However, because Delta is more contagious, 1% of a very, very, very large number of kids is a lot of kids, right? And as a parent, you may rationally say 1% is very low, but there's still a chance that could be my kid, right? And depending on your county, right, depending on the number of infections that are happening, the children's hospitals and other hospitals, right, may be getting filled up, which is going to increase the relative risk of being in that 1%. So my only kind of thing that I might offer on this point is take a look at the local vaccination rates. Be careful about the news you're reading about how bad it is, for example, in like Florida, Louisiana, and things like that, because really we're in a stage of there are multiple pandemics in this country, and it really depends on the vaccination rate of the community that you're in. So I'm not saying don't be worried about this. What I'm saying is take a look at what's happening in your community, how accessible and how available are medical services, because we've had 18 months to figure out how to treat patients, including pediatrics, with COVID, and we've learned a lot. So as long as the nearby hospitals are have the capacity to take children, I think that's something that I hope would offer some sense of, I'm not going to say relief, nothing will be relieving, but some sense of, perspective on kind of the relative risk of where we are now. The other thing that parents are of course dealing with is, I have a child who is still learning, developing physically, mentally, emotionally. What are the cost benefits of keeping him out of school or doing virtual again versus having that very, very small risk of infection? And I don't know how to balance that. That's a decision that your family will have to kind of come to, but that's a legit concern that you want to add into the equation. And I also just want to remind folks that you do have tools to manage the risk, right? So we know that masking works. So in the areas where you have control, right, you can really be much more active on that. Physical distancing, thinking about gatherings, right? And there are things where, testing is much more available now than it was this time last year going into the school year. So if you decide that it's important that your child still is interacting with people outside of the home, you can still set up things where like you're asking folks involved to get tested beforehand to ensure that the risk of exposure is going to be very low. Right? These are things that you can have conversations about to kind of help manage that. That being said, having said all that, I know that this isn't necessarily telling you not to be anxious and that everyone will come up with a different system that works for them. And I really invite people on the call to kind of weigh in on their concerns and how they're managing the concerns for this. So the last thing I'll say is, as with everything COVID, doing everything alone is really awful. So really try to reach out to other folks, other parents who are trying to figure it out and see if you can come up with a shared system of kind of thinking through the risk together. Because navigating confusing incomplete data, waiting for vaccine approvals, and navigating the emotional burdens of caring for a child is really impossible. So that's all I really had to say about I think those things. I'm going to pause here, take a look at the chat. If you have questions you didn't ask it, feel free to put in chat now. Just give me like 2 minutes now as I stop sharing to review the chat and see what questions people have. But thank you for your attention so far. So I'm just going to read out loud the questions I'm saying just so that you see where I am and that we're not just watching me read. All right, so I see a question from Anne about how does the data deal with people who have already contracted COVID and therefore not gotten vaccinated. So I'll address that. Question about from Emily about predicting how many boosters we may need at the end of the day. So I'll definitely be able to talk to that. What is the current goal, again from Anne, for herd immunity? Are people who have contracted the disease counted in the calculation for herd immunity? And is it a thing at all that vaccines historically exhibit negative? Oh, okay, yes. And then there's a question about have we seen negative side effects years and years afterwards? There's a question from Ed about the prevalence and severity of Delta among children, which I think I might have already mentioned, but I'll address that. Great. And then Anne just was affirming some of the thoughts I had about looking at your local situation. All right, so I'll do those in order. I don't think there's a specific order that needs to be done. So let me kind of address those now. So Anne's first question was, how does the data deal with people who have already contracted COVID and therefore not gotten vaccinated? So CDC recommendations are that if you have had COVID previously, you actually should still get vaccinated. And actually there's some data showing that the folks who have gotten COVID before and then got vaccinated have like the highest immunity to COVID. So I think early on when the supply was low, there was some conversation about, well, let's maybe have the folks who already have some immunity from past infection be kind of lower in the priority list. But now the vaccines are pretty plentiful. The recommendation really is that they get vaccinated. So as far as calculating herd immunity, that's a good question. I think different people count it differently. Because the recommendation is that you still get vaccinated, I think most folks are, by folks, I mean most, I think places are tracking vaccinations versus unvaccinated. But I think some people are looking at past, how I say this, I think public data has generally, that I've seen, like especially in Philadelphia, has asked vaccinated versus unvaccinated. But that's not to say people aren't also looking at past infections. Those reports are generally like research teams at specific hospitals who have access to the data from people who are coming into the hospital. So I think it's a little bit messy there. And I think, again, the recommendation is still please get vaccinated, even if you've been previously infected. How many boosters will we need? With any disease, the question will only be resolved 10 to 20 years from now. So no idea. One thing that I personally am, the boosters are available. It's the same formulation as the previous one I already got. I'm not sure how I feel about needing boosters right now. I will go get it once I'm able to, because it's there, and me choosing to not get it, it's not going to suddenly magically make it appear in some other country that needs it. I'm actually more excited and would be more excited about boosters where the genetic material of the mRNA vaccine is a closer match to the variants that are current, right? So this is kind of what we do with the flu vaccine, right? Is we try to match the strains of the flu vaccine to what we think are going to be the prevalent strains of flu that year. And Moderna and Pfizer are testing in the lab, and I think in people now, formulations where the genome of the mRNA is closer to like the Delta variant, because that's going to not just boost your immune system, but also kind of train your immune system to really look to something that's much closer to what we're seeing. So those are the boosters I'm more excited about. I think right now it's a question of Delta is really bad and it's only going to spawn even more variants. So we need to do something. So we might as well use what we have already on hand. I will say that FDA has said that the approval process for a genetically different mRNA vaccine will be faster than starting from scratch. So they're going to use a model similar to what they used to flu. So the process for getting approval will be much quicker. And I think kind of down the road, it's going to be very similar to flu, possibly, where they're going to be tracking coronaviruses around the world every year. And if it dramatically differs, then they will make a new version of it that's a closer match, approve it, and then you'll get it with your flu shot, which, by the way, flu shot season has started. So please, if you're on the call, please sign up and get your flu shots, because that's also a thing that's happening. All right, what's the current goal for herd immunity? The current goal is to still have as much immunity as possible. Right now we are in what is, I think, one of the most difficult and messy times of the pandemic, because we have unequal vaccination. So we're going to see some areas where spread is very low and areas where it's very high. And those situations, if they persist for a long time, are perfect for viruses to adapt to a mixed population and then find even more ways to escape immune response, which I think made everyone's anxiety level on this call just spike dramatically. So take a deep breath. Again, we are tracking things in real time, and currently we don't have any reason to be concerned at this moment. But again, this is why we're doing boosters, is to try to get ahead of the curve, so to speak, on preventing that. But it's a big problem. I'm not gonna lie. It's a big problem when we have huge states with huge populations that are actively going against vaccinating folks because they, just like the other places in the world who can't be vaccinated for a variety of reasons, are providing the host required for coronavirus to find new ways to get around the immune system, because that's what viruses do. So herd immunity, we need as many as, like everyone, as many as possible. Anne also, I think it was Anne as well. Yeah, Anne also asked about, have we seen adverse side effects come up 5, 7, 10 years after vaccination? I really love this question because this has been, I think, driving whenever a new vaccine comes out or any new drug comes out. This is what really drives, I think, a lot of anxiety around vaccinations. Like, yes, I can see from the data that it is safe for the 18 months that you have been tracking this, right? But I don't know what's going to happen 10 years from now, and my child is 5, right? And so this actually matters a lot to me, right? I can say with confidence that any serious adverse effect from a vaccine that we've ever seen in the history of vaccinations has happened at the latest 3 to 6 weeks post-vaccination. Okay, that includes anything as early as smallpox vaccine all the way to, I guess, what was the most recent one before COVID? Whatever, and I can't think of it right now. But really, anytime we've ever seen something we can really truly attribute to the vaccine, it's been 3 to 6 weeks at the latest. And this is not to say that we don't look for it, right? You know, when folks were really trying to push this story about the link between autism and vaccinations, we didn't just say, well, that usually doesn't happen, it's only 3 to 6 weeks. You know, people did the studies, right? And we've done the studies on that question, and the data overwhelmingly against making a link there. So science and biology, there's always the potential for something new. So I'm not going to say never, but the data currently are that 3 to 6 week window. And that's true even for some of these rare side effects that we might be seeing. Actually, generally for the COVID vaccines, even the rare things are coming up a lot sooner than 3 weeks in most cases. Ed asked about prevalence and severity in Delta among children, which I kind of touched on. Basically, it's there's nothing special happening with children, and what I mean by that is Delta on its own is more contagious, so it's about twice as contagious, and we see that in both adults and children. And we don't see, at least in children, an increase in severity. So there are more children getting infected because it's more infectious, but the overall rate, so it's still going to be about 1% of all of those children are going to have severe disease, but that's still going to be a big number. All right, so there's been more questions. I see Luisa, who is my colleague. Thank you for joining, Luisa. Let's see. So when I say unvaccinated, does that include children? So that's tricky, and that's hard to know. I think this is a big problem in the media and in the science reporting, to be honest. I think when we're talking about, like, you know, policies and public health about unvaccinated, a lot of the rhetoric around like why people are unvaccinated or vaccine skeptics really focuses on adults and not about the fact that there's this huge segment of the population who cannot be vaccinated because they have not been approved. So I think what I've seen is most people, when they talk about unvaccinated, are not talking about the children, which is a problem. I think that's a reflection of the larger issue of not paying enough attention and not thinking critically enough about how important it is that we think about those children, how caring for those children is intimately tied to every aspect of our working life, right? Like the policies at my workplace directly impact my ability or the how likely it is that I might transmit to a child that might be in my home, right? And so I think that Luisa's question speaks to the overall problem that the news has and scientists have about really being nuanced about unvaccinated. Right, so Ed was responding about herd immunity. So, and he has, I'll say out loud, he's talking about how current calculations are like there will, quote unquote, never be enough. I think that if I'm misinterpreting your question, Ed, please let me know. But I think what I'm getting from your question to me, which is a direct message if people are looking for it in the chat, is the concern that actually we may never have high enough for herd immunity. what I'll just say is that different diseases require different levels. Like for example, measles, for measles, you really do need like 97% vaccination or immunity to really stop seeing outbreaks of measles. If it drops as low as 95, 94, 93%, you start seeing outbreaks. But for other things like flu or HPV or things like that, it does not need to be nearly as high. And that just has to do with a whole bunch of factors, which I won't get into right now, but if that interests you, I can kind of talk more about that later. So I'd have to look at the numbers and kind of think about it. I think that we're nowhere near that globally, but I'm not sure I'm ready to say that there is no way we can achieve herd immunity. I am not quite ready to say that yet. All right, let's see. So Tracy asked a great question about side effects to the booster. Let me see if there's more questions before I answer that. Let's see. Perfect. Okay, so I think I appreciate all the affirmations as well. Okay, so I think the last question I see here in the chat is side effects. So currently, side effects for boosters, and this has been seen in Israel and in the kind of some boosters here in the US, seem to be really not much worse than what we've already seen. I think just like with what we've already seen with the 2 doses, it's going to be the gamut of some people are going to have basically no side effects. Other people are going to have chills and feverish for like a day and then it will resolve. We haven't seen anything more dramatic than that. And based on how we understand how these side effects are arising from the immune system responding to the vaccine, I don't think anyone is expecting anything more severe, but it is something that we're going to be tracking, right? For example, are those very, very, very rare anaphylactic incidents actually more likely with a 3rd dose? Like those are things that we're going to be tracking. But I think most people, based on our previous knowledge from vaccines, are confident that the side effects will most certainly not going to be much worse, but we'll see. And like I said, we're basically repeating the beginning of the year as far as the order in which people are going to be available. So I got vaccinated in May, so I still got some time to wait to see what happens, but I feel pretty confident the side effects will be manageable. I think I handled all the questions in chat. So I'm going to invite folks. Oh, here comes one more. I want to elevate what Luisa's putting in chat that just came in. So she says, thanks for my response to her question about, again, is the term unvaccinated referring to just adults or also the children? And so she continues, I think language matters and people need to be clear if they are including kids or not. If they are, then they should say that the unvaccinated, including children, since those under 12 have no choice right now. So I'm interpreting some of what Luisa you're saying as we need to be very clear about who we're talking about, and also be clear that a lot of unvaccinated people, and I'm going to say people now, including children, right, don't have a choice, right? And our attitudes, perceptions, and policies really need to reflect that, right? Like, as tired as I am as a virologist and educator, having almost daily conversations with people about vaccines and whether they're safe and things like that, right? It would be very easy for me to be jaded and just be like, I'm so tired, like, yeah, we have a vaccine mandate, deal with it, right? But I think that we need to be careful about that attitude in general, because that doesn't really help increase vaccination. And in particular, it allows us to ignore the fact that actually a lot of the people who are unvaccinated are unvaccinated by choice, right? And that's something that we should still be thinking about and making policies with that in mind. So I thank you, Luisa, for your thoughts on that. What are my thoughts on vaccine mandates for events, workplaces, etc.? And Tracy's asking, can you help me understand what the exceptions are for health and religious reasons? I'm gonna do the easy question first, which is Tracy's. So exceptions. So before I answer both of these questions, I want to again emphasize I'm a virologist. I'm not a policymaker, and these 2 questions are leaning into policy decisions and legal precedents, which is not my area of expertise. But I can still speak to that. But I just want to be clear about I'm speaking from, this is not my domain of knowledge necessarily, right? So for exceptions, medical reasons, these are going to be things where there are some children, adults, et cetera, who maybe have an immune condition. For example, instead of being immunocompromised, they may have an autoimmune disorder and very specific ones where really any vaccination would be a risk to them because their immune system may do something really weird, right? There's some very, very rare diseases out there that may just have increased risk to bad reaction to being immunized, and they're almost always immunologically related. And so those are things where the medical community will pretty quickly understand, like, these people are just definitely too risky to take it. Some of those people who are like in the middle gray area of risk are in that kind of high risk adults kind of step that I mentioned. So, we'll still, test it in cancer patients who are on chemo or coming out of chemo with a low immune protection there to see kind of what happens with their consent, obviously, because these are clinical trials. So that's what medical means. And those are basically when someone files for a medical exemption at a particular organization or whatever, there will be someone on staff who will have the credentials to assess that. And that person is not going to be making a decision on their own. They will have received guidance from the CDC and other places about these are the type of medical conditions that we really should be exempting for this particular vaccine. So that's how medical exemptions are handled. Religious exemptions are a very thorny subject and very complicated subject. All I will say on that is that different states write their religious exemption laws differently in such a way that when you file for an exemption, you have to kind of provide some type of proof or justification for the exemption, and the bar you have to reach for being granted exemption is going to depend on literally the way the law was written in the state. So it's really a state-by-state basis, and that state legal precedent will inform how workplaces then process religious exemptions. So it's complicated, and that's really all I can say on that with any kind of confidence. I think if people are really interested, this is, I guess, for the Science Center staff here, if people are really interested in learning more about exemptions and all that stuff, I think it would be great to recruit a public health policy expert or a legal expert to kind of talk about the history of that. If anyone on the call has the expertise and wants to weigh in on some of that, I really would invite you to do that. Before I invite that, though, there was also a question about vaccine mandates for events, workplaces, et cetera. And again, I'm not going to say yes or no, you should do this. I think that is a value decision and a policy decision that your workplace has to come to decide. There is a lot of legal precedent for fully approved vaccines to be required, especially in the event of a pandemic. And so that's something where all I can say is your organization will want to reach out to legal counsel who can give you good advice about whether you can institute and what the legal vulnerabilities or protections you might have for instituting that. I will say from a public health standpoint, appealing to people, and this is also true of other things like diversity, equity, inclusion issues, right? Appealing to people's better nature to do the right thing doesn't really work. Really, it's policy that makes things happen. So if you institute mandates and requirements that is going to drive behavior, that is, in public health, that has always been the most effective strategy at getting things done, right? So if you want the bar to be everyone's vaccinated, then the policy has to be everyone is vaccinated, right? And so that's just speaking from like what works in public health. And so having said that, I would say instituting requirements and mandates at this present moment is very much in line with a public health effort to kind of get around this pandemic. But that's not me saying you should or shouldn't do it. I'm just saying that's how it fits into the specific public health strategy that we're trying to do. And again, with the approval on Monday, it's going to provide a lot more legal protections for folks who want to institute that. But it's a hot topic, and that could be a topic for another session. All right, I want to pause. There's more questions in chat, but I've been talking this entire time. I just want to get, if people want to weigh in themselves and add their literal voice to the conversation, I do want to invite that as well. So I'm going to just take a moment. If anyone on the call would like to actually speak their question, right, or want to respond to anything that's been said, I really want to invite that. So if you feel so moved, please, in the reactions button, use the raise hand feature or say something in chat that you would like to speak. I'm just going to stop talking for like 20 seconds to give folks a chance to volunteer to do that if that moves you. So anyone want to add anything with their voice?
Hey, David, I just want to, or Jason,
Yes.
Dr. Diaz.
Yes. Hi, Anne.
Hi, this was so awesome. You are excellent. And I just want you to know that I turned the volume up way up when my 24-year-old vaccine hesitant little bebopper came into the kitchen to hear this. I turned all your stuff up, all your answers, all your presentation. So thank you. Hopefully, move her off the fence, but it's crazy now with, I just think 20 somethings and a lot of people just don't trust anything anymore.
Yeah.
And that we've allowed a lot of trust to erode, and you just can't rebuild that overnight. But with people like you and authentic voices close to the ground, I think it really makes a difference. So thanks for being here today.
I really appreciate that, Anne. And one thing I'll say in response to kind of, I think some of the challenges that you're experiencing, or at least the desire for your kids to get vaccinated. This pandemic has been a huge learning experience for me. I've tried very hard to be very clear about where my expertise ends and kind of where I'm stepping out of my expert zone. And that's really important to me because there are lots of people who are a lot more expert than I am. And one of the things I'm learning, right? I'm a virologist, which means I understand how viruses work. I don't understand how people work, right? And so this question of like, how do we get buy-in from folks and get them excited? Because like for me, my trust in the vaccine is probably because my expertise on how these things work. I just have a lot of trust in it, but I have a particular perspective that is not shared by the vast majority of people I will ever interact with. And I have also had to learn, how do I help address these concerns? I mentioned I come from an immigrant family, and that has a couple of things for the pandemic. And for the most part, my extended family have gotten vaccinated, but I have a couple of folks, close family, who are still hesitant, right? And I've had conversations with them, and it can be difficult. And I think the only thing I will say is, this could be a whole other topic for a whole other session. What doesn't work for folks who are, especially at this point you're so hesitant or resistant, citing data is, going in with data is not going to work. That just will not work. Because if that was going to convince them, they would be convinced, I would say, by now. I think for me, what I have found is effective, but it takes so much time and energy, is I would encourage you to want to really legitimately want to hear what their concerns are and really validate them. Right? Why is your child, so why is your child, your daughter, I think you said, why is she skeptical? And when she says what she's skeptical about, validate that. Yes, we should be skeptical. I'm a scientist. We should be skeptical, right? But then how do we?
There's a part of me that's like really proud of her
yes,
for being skeptical and for asking these questions, because her questions were great and her rationale. And one of the things that really, made her dig in a little bit more was that she really resented the fact that on social media, the people who weren't getting vaccinated were being just derided as stupid and,
right,
and idiots and unpatriotic and everything else. And she was just like, that's BS. Like I'm listening to these people and I'm asking questions and I'm not stupid. And so there's so much psychology going on in all of this. It's just, on one level it's horrifying, like the whole experience. On another level, it's completely fascinating, this whole thing.
And we know that young people I'm still relatively young myself, I'm in my mid-30s, but I'm hopefully getting over the feeling invincible stage. I definitely don't feel invincible anymore, right? But we know young people in general feel invincible. I teach college students, I know, right? And so that's also feeding into, in addition to being skeptical, feeling like, I think the way that young people are thinking through the risk themselves is different than I think a lot of the people on this phone call, right? And so those are tricky conversations. Honestly, they are long, heartfelt, emotionally fraught conversations oftentimes. And I don't know, do I have the energy for that? Most days I just don't, right? It's so much easier just to like shut them off. And so this is a collective struggle. So I just say all this just to really empathize with kind of your struggle. And I'm happy that you feel that our conversation today has been helpful. And I think it's hard to be compassionate after having experienced so much pain and concern and things like that, and feel like, well, I'm already suffering so much, why do I have to give you the time of day? But I think the more that we can try to like create space to do that, I'm hopeful. But again, policy is really the best thing as far as like, you have to do it. And those conversations might be to help them understand kind of how they might think through responding to that policy. There is some chatter in here about fake IDs. That's a complex issue. There really isn't a great answer. And as a virologist, I'm really concerned about that, because what proportion of the documentation coming in to like my school and other businesses are real vaccination cards, right? So like when we see like vaccination rates, like what's the error bar on those numbers, right? I really don't know. That's a concern, right? So I would just automatically, whatever number you say, I would just imagine it's a little bit lower. I don't know how much lower, but I would just imagine that, especially if you're including people in their 20s, because that's kind of where we're seeing a lot of that, I think. Well, I shouldn't say that. I think also older adults are also doing that. So I'll have a great response to that. I want to just clarify, I want to note, it is 6 o'clock. So I think I need to stop it there with formal question response. I think we'll probably end the recording. That being said, if there's like one last question, I'm happy to stay for another maybe 5 minutes to answer those. But I want to thank all of you for your attention, for hearing me yammer on for an hour or so, right? I thank you for your questions, and I want to also thank the Science Center staff for once again inviting me back to be a part of this. So thank you all. Stay healthy and stay connected. And again, thank you.